Hi, this is Dr. Eric Thomas speaking for Nutmeg Dermatology, and I thought today we would talk about the number one, the most common malignancy of all types in the United States, basal cell carcinomas. Now, they're often said to be low-grade cancers, but that has to be put in perspective. Yeah, they're low-grade because they almost never spread internally. That's good, great, wonderful, but they unfortunately have a tendency, majority of them anyway, to occupy high, expensive, high-quality real estate, namely your face. Oh, they can show up, obviously, on the shoulders, back, arms, and even the shins in older people. But I like to think of Mr. Rogers. He likes the neighborhood he grew up in. Great, that's fine. He doesn't usually move around a lot. Yeah, those are basal cells. But as I've already said, he occupies the expensive side of town. So you really want to catch them pretty early. Now, it's hard to give you a great description as to their appearance. They vary a bit. That's one of the things I love about biology, that there's a lot of variability built into it. Having said that, the routine, the traditional appearance is a smooth, almost dome-shaped little bump. Could be the size of a pea, could get much larger if you leave it there. It does tend to have a glassy or shiny appearance, and usually does not have a lot of color. But I'm thinking back to what I removed from a fellow's shoulder a few years back, and I really thought it was a melanoma, or at least was concerned about it, because it was terribly black. So a rare basal cell carcinoma, for indeed that's what he turned out to have, can have color in it. They also can be destructive. Some basal cell carcinomas have a somewhat raised border and the center's depressed a bit. And then there can be outright destruction with some bleeding eventually. So we want to catch it well before that happens. Now, how do we diagnose it? Unfortunately, there's no blood test, and we could be pretty suspicious on a clinical let's look at it basis, but we really need to eventually take a little tissue, and don't worry that much. We use a very small needle. I don't know if you know the ideas and sizes of needles, but the type of blood, the needle that's used to draw your blood is considered a 21 or 21 gauge needle, and we generally use a 30 gauge. They get smaller as the number gets higher, so it's really very, very small. We also have a little trick where we neutralize the acidity of the lidocaine, the novocaine, so it doesn't burn quite as much. Anyway, that having been said, we either just remove the whole thing in one fell swoop. If it's small enough and in a great location, we just cut it out, put in some stitches. If it is a basal cell, hey, it's gone, as long as the margins look good. But sometimes we have to take just a sample, a biopsy, and wait till it comes back from the lab. If it comes back as a basal cell, then we have reached that famous fork in the road. And one side of the fork goes to surgery, and the other side goes to no surgery. And I'd rather talk first about the no surgery side, since certainly that's what most people would prefer to do. What we do is we use very soft radiation therapy right in the office, have a full-time radiation technician who may be doing a YouTube on her own very soon about this. And that is well liked by people. We've had very good results. Most studies show that the new equipment that we're using has the same cure rate as surgery. We also have ultrasound on the equipment, so we can actually see what's happening each time we give a person a treatment with a weak radiation therapy. Sort of the same energy that your dentist would use for x-raying your teeth. In any event, the advantages are it does not hurt, it doesn't scare people. I've had a lot of older people who just didn't want to go under the knife again. And generally for the next 20 to 30 years it does not produce any scarring beyond that which was already there from the any destruction the basal cell did or any surgery that was done to diagnose it. So that's a very good technique. It has some drawbacks. It does take a number of visits. The other fork in the road is surgery. What sort of surgery is there? Well, I've already mentioned that we could, if it's small enough and fits well with the lines that the skin likes to be cut, and there are lines that are considered the lines of least resistance, we just cut it out, stitch it up, there you go. Unfortunately, if it's in a complex area, nose, ears, etc., then there is an older technique called microscopically controlled surgery. I shouldn't say older. Actually, X-ray has been used for longer than microscopically controlled surgery. Just the equipment's gotten much better recently. In any event, microscopically controlled surgery, also known as Mohs surgery, named after a surgeon, Frederick Mohs, now deceased, was brought out to be a way of gradually whittling down a lesion, checking it at each level, and doing more if required. Unfortunately, before starting, it's hard to know whether the lesion, whether the basal cell will penetrate through the full thickness of the side of the nose or be much shallower. So until it's done, there's always a risk of requiring a skin graft or on rare occasions, on occasion, requiring a flap from the cheek to complete closure of a surgical site. There is a cream, 5-fluorouracil. It is approved for extremely shallow, multicentric basal cell carcinomas, not frequently usable. So there are your major ways of treating it. I hope that you never have a basal cell, but it's easily handled with minimal discomfort, a bit of work though, if you just catch it early. So we'll tell you more about the other types of skin cancer later, but that's it for the number one, the primo skin cancer of all types in the United States, basal cell carcinoma. Let us help you find it, and if we find one, let us go through the options, because there are options and you should know about all of them before proceeding. Thanks.